Sawubona. In the Zulu tradition, when we greet people, we say Sawubona. And really it is about the direct translation, which is about I see you. And so in this Jubilee year here in the faculty, I say Sawubona. Because in this year of Jubilee, we will reflect on our legacies of achievement and transformation. We will recognize the contribution that our faculty continues to make to a brighter future for all South Africans. Sawubona. And so when I come today into this space, I want to see you in a particular way. And I want to see and recognize on this occasion, particularly Katherine's contribution to the faculty enterprise. And as we see each other more clearly, we celebrate and value our research endeavors, which enhance our reputation locally, nationally, and globally. But importantly, and I think the work we come to celebrate this evening particularly locates it in the impact that makes in society. Because what are we as scholars if we're not changing the world that we live in? We might as well blow whistles, I think. But this week has been an important week because it started with Mandela Day. And on that day, Don Matera died. Matera's own journey reflects this idea as he changes in his own life from a gangster in the Westbury Township in Johannesburg, a life of trauma. He takes this trajectory across life into a world-renowned poet and social justice activist. And even in that journey, he reveals our capacity to change. And sometimes it is the information that we create at places like ours, in this faculty, that allows us to change in a reasonable way. But he wrote this, and I think as I think of the work we're celebrating today, I think this resonates for me. Don Matera is quoted as saying, "My mission is to help remove pain and suffering from people's lives, to remove an invisible chain. My work is a shadow of my actions." And I think when we reflect on our scholarship and the things we bring into an inaugural lecture, that's what we are doing. We are saying in an inaugural lecture that the scholarship, the professorship, celebrates an individual's achievement. The inaugural lecture offers an occasion for that knowledge to be shared with the community that is broader than the particular discipline. And so even as we renew our tradition of inaugurals in the faculty, it's this kind of engaged scholarship that we want to speak to. So when I invoke Kamirodi Gys, which is what the name the original peoples in this area gave to observatory, they called it Kamirodi Gys, the place of the stars. We recognize our role as scholars, that this is the place from whence the light will come. So we're not a place of human stars. We're a place in which we create knowledge that shows a different way, a better way of being. And that's the kind of story I want us increasingly to be telling as a faculty. Doesn't mean we don't recognize the traumas in our history, but it is about recognizing a brighter future. So in this Jubilee year, this is the second inaugural lecture we're having this year. There will be a series that follow. I don't know whether intentionally or not, but mainly by women in the coming months. Again, because I'm recognizing that in the stories that are told of the legacy of this faculty, the stories of women are attenuated. One doesn't always think first of women as the heroes in academia. And so part of this process in Women's Month next month, we will do that again. And so the inaugural lecture is a chance for the scholar, recognized by their peers, to reflect themselves to a broader community. And so I welcome Professor Dan Steyn to present the candidate for the inaugural lecture today.
Dean Green-Thompson, Director of Specialized Services, Carol Dean, Emeritus Professor Robertson, colleagues, friends and family, Ian and Kelly, and of course, Professor Sorsdahl. It's really wonderful to have the opportunity to introduce Kat this afternoon. As Lionel was saying, my job is to provide a little bit of broader context to Kat and to her field and to set the stage for the inaugural address that follows. Whoops, I missed Emerita Professor Berg. Kat is the head of our Division of Public Mental Health. And as the first head of the World Health Organization was fond of saying, there's no health without mental health. And so I'm pleased that we'll again be paying attention to this point today. And of course, while basic neuroscience and clinical care are absolutely crucial in mental health, a public health perspective is needed for the big picture. What are the social determinants of mental health? What's the best way of preventing mental disorders? How do we best structure our services? Professor Naledi is here and can speak to this sort of point. And these kinds of questions are hugely important. And it's really crucial that Kat and her division are working hard on them. Now, there are different approaches to public mental health. And one of the tricks of the trade of public mental health is to always begin with a model. So I guess my model involves 3 dimensions, which I hope will give a sense of Kat and her approach to public mental health. I call it the 3P model of public mental health. The dimensions are planning and problem solving, positivity and play, and parenting and peacemaking. And I'm looking forward to an editorial from the division shortly about this insightful 3P model. Let's begin with planning and problem solving. So a quick qualitative study of Kat and her colleagues revealed that she's the one who understands not only the big picture, but all the moving parts and how they fit together and how everything is going to pan out just so. And it turns out that her father, Neil, was a military man and in charge of logistics for the Navy. And so perhaps from him, Kat inherited her ability to plan everything just so. And no matter how massive the study, no matter how many people are involved, but it works out for everyone. She was also an events manager for the Canadian Embassy in London, finally honing her logistic skills before she came down here. So here in South Africa, the number and the quality of studies undertaken and the number and quality of the students supervised in the division is absolutely remarkable. And we'll hear more about that. Now, notably, Kat's work has often relied on what's called problem-solving therapy. It seems to me that this is not entirely accidental. It really reflects her own approach to life. You may think it's only a boer wat 'n plan maak, but it turns out this is also a feature of life in the Pacific Northwest. And Kat is an absolute whiz at helping students take complex problem and reduce them down to something that's simple and straightforward and manageable. Here in South Africa, where there are vanishingly few psychiatrists and clinical psychologists for our population, Kat has been able to show that people in the community health workers, are able to, employ problem-solving therapy in a range of different contexts, and that it's useful. And so this is very, very practical and very important for our local contribution to public mental health. Let me move on to the second dimension, positivity and play. It's very easy to know when Kat is around because you just have to keep your ears open and you basically hear these peals of laughter. And when you get closer, you then see her broad smile. And one of Kat's PhD students said to me, look, her stock phrase is, "You're nearly there now." And she repeats this over and over, including in chapter 1, where there's a whole thesis to go. So no matter how many chapters we've done, hurdles we've gotten over, the refrain is the same. Kat's wedding cake was delivered by a colleague in the department whose name I won't mention because the cake fell in on itself on the way to the wedding. Fortunately, Kat thought this was absolutely hilarious. And she managed to turn the whole episode into a game. See who can lick the most wedding cake off the back seat. So here in South Africa, where mental health services clearly have challenges, this sort of positive, proactive, and energetic approach is very welcome. Along the same lines, when it comes to studies, Kat is the first one to develop a logo, to come up with a sassy acronym, and to develop a range of cartoons and drawings as study resources. Turns out that Kat's mom, Leslie, loves playfulness and embodies joyfulness. So Kat doesn't just announce the results of a study. She does a cupcake reveal, you know, this thing where it's either pink or blue, boy, girl, arm A, arm B, you know, everything is a game. And when she runs out of ideas, she brings in the division's play consultant, her daughter Kelly. And between Kat and Kelly, a creative injection of fun will be given and things will get moving. So, you know, as a biological psychiatrist, it's clear to me that playing is an overlooked part of psychiatry and medicine. And I'm delighted that Kat's brought this to bear on public mental health. And so finally, let's talk about parenting and peacemaking. So it turns out that Kat's dad was not only a logistician, but he was also a diplomat. And the important lessons she learned from him and others have been key in her public health work in several ways. So it turns out that when you're dealing with public health services and policymakers, it requires being more than a bull in a china shop. Who knew? Instead, it requires painstaking investigation. Another one of Kat's aphorisms, show me the data. So very careful investigation, strong interpersonal skills, and the ability to bring people together. So Kat is the sort of person who, as the Irish saying goes, will tell you to go to hell in such a way that you actually look forward to the journey. So her parenting and peacemaking skills have been absolutely key to the success of the Division of Public Mental Health. I think it's undoubtedly the strongest in the Global South. Professor Swartz is here, so we need to point out the close collaboration with Stellenbosch University. It's on a par, I think, with many in the Global North. And under her, the division has grown in size and scope. It's mentored students from around the country and from around the continent, and it's generated an amazing range of research, teaching, and of community engagement. My strong impression is that this has happened in part because of Kat's interpersonal skills and her real, it's more than interpersonal skills, it's her real care for people. She does put the people in her division first, and she puts her students first, with the slight exception of certain animals, such as Aurora, Lockie, Katniss, and Willow. What's key is the well-being of the people in the division, and over I've heard from people in the division talk about her inclusive style, her warm style, her caring style, making sure that everyone from project managers to field workers is involved in presentations, gets the kudos, and feels part of the division. I've known Kat a while. As I recall, she contacted me with the notion that there might be something novel to say about traditional healers in South Africa. Asked why South Africa, her response at the time, jokingly I assume, was that it was the absolute furthest point from Vancouver. Less jokingly, that she wanted a different perspective. So I did my usual sink or swim. I sent her to Johannesburg to the South African Depression and Anxiety Group and watched from afar. In that pool, you know, at that time, I don't think she expected to stay more than a year, and I didn't expect her to stay more than a year either. But in that pool, she raced. She absolutely raced. Soon she was crisscrossing the country, giving psyche education to different communities, meeting with traditional healers from a whole range of contexts in the country, and publishing quantitative and qualitative studies of what she was doing. And then meeting Ian shortly thereafter meant that she didn't get out of the pool. So, so Ian, we're very, very grateful for that. Thank you also, Ian, for the multiple contributions you've made to different studies, driving people around, supporting Kat, pitching in various ways. Kat, in the several years since she worked at SADAG, has taken public mental health to really important new heights. I won't list all her massive achievements in this brief introduction, but I did want to highlight her work in training people from around Africa in public mental health, including many people who make important decisions. Her close collaborations, Western Cape Department of Health and Wellness, including Tracy and Carol. The work that she did on the Life is the Many trials, using that particular tragedy to highlight the need for better mental health care and to advocate for that. And the multiple really innovative and really informative clinical trials that she and her team have done, which have really moved public health forward in a major way, not only locally, but as Lionel was alluding to, globally. So Kat, your division and many others here in the room and many others in the country owe you an enormous debt of gratitude. Thank you so much, and we very much look forward to you addressing us.
Well, thank you, Professor Stein and Professor Green-Thompson, for that wonderful introduction. It really is an honor to be here today and to see so many friendly faces in the audience, and of course, those joining us online. I am going to jump right into it because we have a very short period of time, and I will try to make it very, very brief. And just to say that although I will be talking about mental health challenges here in South Africa, many of the challenges, opportunities, and lessons learned are applicable to other low and middle income countries as well. Just to give you a very brief overview, I'm first going to highlight the problem, the prevalence, the burden, and the treatment gap in the country, which is very much the crux to this presentation. I'm going to go on to describe some of the contributors to this treatment gap. And moving on from that very quickly, because I think I could probably spend 3 hours just describing this problem because it's quite complex, I really want to move on to discussing the solutions and how we can move forward as a country. So what do we know? We know that mental disorders are highly prevalent globally, and South Africa is really no exception. About 1 in 6 South Africans can be diagnosed with depression, anxiety, or substance use during a year. And this was data that's extremely old, although it is nationally representative, which is wonderful. And it was also done before COVID, where global estimates have seen a much more an increase in depression and anxiety since then. But despite these old numbers, I think these numbers do speak for themselves, and it's only increasing. And alongside this increased burden, we're also seeing a rising burden in the form of disability-adjusted life years. And this is data from IHME, the Institute of Metrics and Evaluation. And as you can see, regardless of any country, whether you're in high income, low income country, the trend is pretty clear. We're on the rise. And despite this high prevalence and very substantial burden, most people living with a mental disorder do not access the treatment that they need. About 75% of South Africans living with a mental disorder do not receive the treatment, and that only includes those for common mental disorders. If you increase to severe mental disorders, that's 89%. So this gap is extremely large. So let's just put this a little bit into perspective. Imagine a health problem that affects 1 in 6 of us, if we look around, that has a significant impact on our relationships, our working lives, and ultimately our quality of life, where effective treatments are available, yet only a quarter of people actually get any treatment, and we don't even know what the quality of that treatment is. It just seems kind of unfathomable. How can this possibly be the case? Would it be okay if it was to diabetes, cancer? Why is it okay for it to be the case for mental health? And I think this leaves people in the room who work in the field and those people living with these disorders quite perplexed. How is it possible? Well, I wish I could say that there's only one contributing factor to this large treatment gap, but unfortunately it's quite complicated. And as I said, I will only mention just a few of them. So first, we know that mental and mental health services are not considered a priority. Despite mental health disorders being responsible for 3/4 or almost a quarter of the burden of disease, only 4.6% of the public health budget is given to mental health. Further, our mental health policy and strategic plan that was put together with many people in this room and was very comprehensive, met a number of barriers and challenges, was not implemented well, and has since then expired. So right now we do not have a mental health policy and strategic plan, further pointing to the fact that mental health is not considered a priority. And I probably don't even need to mention what happened in Life is the Many, where 144 people at a psychiatric facility died out of neglect. So I was an external panelist, as Dan had mentioned, for the Human Rights Commission. And I was really trying to look at some of the systemic issues and what was really happening on the ground. And we had people from all the different stakeholders, from all the different provinces. And it was just quite concerning that all of the provinces and all the stakeholders really struggled to implement this mental health policy and strategic plan. And we're even struggling to show data on what was being offered in their provinces. This is just a study that we had done recently. Tandy Davis, I think, is also in the room. We're working with 7 other countries, and we were trying to look at how did COVID impact on mental health services? And we used the Western Cape as an example. We took data from a number of places. We took it from the actual DHIS. We did qualitative interviews with healthcare providers. We looked at a number of things. And these are just 2 quotes from some of the healthcare providers that I think really show how mental health needs to be prioritized. In the hospitals, we are doing our best, but the infrastructure is terrible. We are understaffed. Patients aren't getting the best care to support their recovery. I think that just got exacerbated because, as I said, you would do services as it was. People got even less. It got more dire. I don't think that anybody thought about the mentally ill. If you already have a service that has been grossly underfunded, if you're removing more resources, the knock-on effect of that is just profound. Things just got harder, and they were already hard. What COVID has done is had pulled the scab off something which should never have been allowed, but it has exposed. It exposed the gross inequity or the under-resourcing of the system. There's absolutely no slack in it. There is no give-in. That just kind of gives a bit of how hard it really was for people during the COVID epidemic. So this is another contributor to our large treatment gap, and it's really that the limited available funding and resource that are available are targeted at psychiatric services. So only 4.6% of the total budget for mental health goes to mental health generally, but 86% of that goes to inpatient care. So that really means that only people with severe symptoms are able to access any treatments, particularly at these more inpatient facilities. And this is really the opposite of the World Health Organization's pyramid that you can see here, where the idea is that services should be offered at all levels, depending on need and the severity. So essentially, ours isn't like this at all. All the services are offered in this apex. Mental health literacy and stigma is a huge contributor to this mental health treatment gap. A lot of research has been done over the years. Mental health literacy refers to knowledge and beliefs about mental disorders that can aid their recognition, treatment, and prevention. And of course, stigma is the form of public stigma that people see, but also internalized stigma of people living with a mental disorder can actually internalize and cause some major issues for treatments. And I think what's really important is to be aware that these attitudes, these negative attitudes and beliefs aren't just prevalent in the population, but also amongst healthcare providers as well, further contributing to this large treatment gap. So I have mentioned a number of structural and systemic barriers to the delivery of mental health care services, but a key one for me is just the availability of specialist healthcare providers. We have about 0.31 public sector psychiatrists and 0.97 public sector psychologists per 100,000 of the uninsured population. This is clearly not enough. And as a result of this, few resources are being provided at primary care. For many people, medication is the essential provision, and there's hardly any counseling being provided at primary care or other levels. But as I mentioned, I'm going to continue to not describe the problem because I think that researchers from time to time get criticized for spending a great deal of time and emphasis trying to describe the problem. And I really think it's time for us to move forward and just try to narrow this treatment gap. And most of the work that I've been involved in focuses on counseling or psychosocial services. So that's where the rest of this presentation is going to go forward, given that's my area of expertise and interest. So solution 1, and knowing that there's 7 solutions, you can kind of see when my presentation is going to end, as I can see my 7-year-old in the front. It makes it easier to count. So solution 1 is task sharing. And it's really about for us to overcome this constraint of limited specialist mental health care providers. South Africa has endorsed the World Health Organization's approach for task sharing counseling to other non-specialist care workers. These non-specialist care workers could be doctors, traditional healers, religious advisors, teachers, really anybody who will take up this service. And I think what's really interesting is this isn't a new idea. We borrowed it from the HIV world. So anyone in here, thank you very much for all your contributions. We've definitely learned a lot. And hopefully as we move forward in South Africa, we'll be able to look at task sharing in a meaningful way. So my solution 2 does expand on my solution 1, which is about using task sharing by integrating mental health care into primary health care services. I think this is really important because, as I mentioned, there really isn't many services being offered at the primary health care level or in other areas there. So a lot of work has been focused on task sharing over the years, and these are just the logos that I've been involved in, or the projects that I've been involved in, and there's been so much more. Most of the work has really been highlighted about integrating into primary care using facility-based counselors. And I'm going to just mention 2 research spotlights here because I don't have time to go through every project, but I'm happy to answer any questions at a later time. So the first spotlight is when we were integrating screening, brief interventions, and referral to treatment into emergency centres. And I think there's quite a strong rationale for this. About close to half of the individuals presenting to emergency rooms in the province have been using alcohol and other drugs. And looking at the impact of banning alcohol in emergency centres during COVID also kind of points to this. And most alcohol-related injuries do not necessarily involve people who are dependent on alcohol, but are rather using alcohol in risky and hazardous ways. So this makes the emergency department an ideal setting for screening and brief interventions to occur that allows you to take that opportunity, that teachable moment, where people are having a little more insights and thoughts into how alcohol is impacting on their life and their family. So this is what hopefully our weekends look like. You work very hard Monday to Friday, and maybe you celebrate on Saturday and Sunday. But if you're an emergency doctor, it looks probably a little bit more like this, because those emergency, they're full. And it doesn't always look like this, where it's going quickly and everyone's kind of getting triaged through. In actual fact, there's a lot of waiting in these emergency centres. So this is really where we started to look forward. So given the strong rationale and in collaboration with the Department of Health at the time, in fact, Tracy Naledi was at the Department of Health at that stage, we decided to collaborate and conduct a randomized control trial to look at brief interventions to address substance use in emergency centres. We specifically tested 2 interventions. The first one was based on the WHO assist length intervention, so it's about 20 minutes with a motivational interviewing framework. And the other intervention was more of a blended. It was a blended problem solving and motivational interviewing intervention. So that was Project Strive at the time. It was quite an exciting project, and it was the first time we had tried to conduct this kind of randomized control trial. This just gives you a bit of information of the patient flow. So about over 2,736 patients were screened, and 335 were randomized to our 3 groups. One was the control with 110, the motivational interviewing group 113, and 112 for the blended motivational interviewing problem-solving therapy group. We did a 3-month follow-up only, and as you can see, we did have quite a high attrition in this study compared to other ones we have done, but it also had to do with being in a hospital setting that wasn't always close to their families. So it wasn't necessarily primary care at this stage, it was more the hospital setting. But what did we find? Very briefly, our MI intervention was not effective in reducing substance use. It was only that 20 minutes intervention. However, our blended MI-PST intervention was very successful in reducing substance use at 3 months. And it was also very successful in reducing depression at the 3-month follow-up. And that's not surprising given what we know about problem-solving therapy and its effect on depression and anxiety just more generally. So after that, Premier decided in 2015 on a few game changers at the time, and one specifically focused on alcohol use. And led by at the time, Tracy Naledi was still in the Department of Health, and she took this forward, rebranded it as Teachable Moments, so no more Strive, Teachable Moments, and we went forward. So a brief overview of the program. It was slightly different than our Project Strive. We were at 3 hospitals, so we were at Par Hospital, Kailicha Hospital, and Heideveld. Our counselors were employed by NGOs in the area, dedicated just to give this counseling. Because of the way the emergency centers work, they did have to work 12-hour shifts, which was quite interesting and a challenge at that stage. But our training was very intensive. We had 2 weeks of training. 1 week were just principles of basic counseling and core competencies, and the second week focused on specific treatment modalities, so the MI-PST approach. Our counselor is here, Megan Milan, so she was responsible for weekly supervision. And it was during this time that we really came up with a structured supervision model that was so important. I often sometimes think the supervision model is more important than the intervention as we kind of move forward. It was very structured, but at the same time, I guess, but many of these counselors were also from those areas. So it very much ended up becoming a bit more of a trauma-focused supervision, even though that wasn't our major intention at the beginning. Just to give you a very brief overview of what we did within this year. So this was very much the implementation science kind of study. So in 1 year, we screened over 4,000 at each of the sites, at each hospital. Of those, between 21 and 47% met criteria for risky alcohol and drug use, which is really quite high. Not surprising given we knew about the literature, but it really was quite high. And I think even more interestingly is of those who screened positive, between 74 and 88% got a session 1, which was an entire 1-hour session of longer motivational interviewing, because we knew the 20-minute one wasn't as effective. So we really found a lot of people getting the intervention, which was wonderful, although we didn't have many people that wanted to come back for session 2 or 3, and there were many logistical problems, again, because they were at a hospital. So we were really trying to get the interventions into the communities. And as you can see here, it was mostly alcohol that was causing many of the issues that they were screening positive for, less for drug use, and some sort of polysubstance use. And if anyone wants any more information about implementation science, my colleague Claire van der Westhuizen has these 2 papers really focusing on implementation science outcomes of this study. So moving on to Research Spotlight 2. So after the results of Project Strive, we were felt really energized, and we really wanted to try this again, although in retrospect, we learned a lot. We wanted to take it forward, and also Tracy and Letty also thought that perhaps we should take it forward and see whether or not we could find the similar results in other contexts. So with Bronwyn Myers and I, we found another team of senior academics to see if we could expand this to chronic disease care. Our colleagues are here in this proposal paper. But Project Mind was funded from the UK, it's UK funding, and it had several aims. We first conducted formative work to develop an integrated service to find a delivery model that would be effective, feasible, and acceptable. So we didn't really know what that model should look like, because this was chronic disease care. And we wanted to know whether these approaches were relatively effective compared to treatment as usual. And we wanted to focus on depression and risky alcohol use as primary outcomes. And we also looked at HIV viral load and HB1AC as secondary outcomes as well, but we're very much focused on symptoms for this study. Our 2 models, we had a dedicated approach where we added an individual whose responsibility was just to provide mental health counseling. Just that. They were trained to do this the entire time. Whereas our designated model, we identified someone who was already in the team to add to their workload to do mental health counseling. Same intervention, same training, the model was slightly different, and we had the treatment as usual as well. And just to give you a bit of background for how the study worked, we had 24 clinics were randomly assigned, so it was quite a big cluster randomized control trial. Treatment arm 1 was a treatment as usual. Arm 2 was a dedicated site where we added the counselor, and arm 3 was a designated site where we identified someone within the team. We did a baseline assessment, they got their intervention, and we followed up at 6 months and 12 months. And we have a colleague, Sue Cleary, at the Health Economies unit, who's doing a 24-month assessment of these patients. To be included, they had to be over 18, being taken ARTs for HIV or medication for diabetes, and screen at risk for alcohol and or depression. The intervention was relatively the same. 3 sessions of MI-PST with an optional booster session. The idea was that MI would help people build readiness for change or counseling, and then the problem-solving therapy approach really focused on how to solve problems that can be changed, deal with intrusive thoughts. We had a lot of CBT pieces in there, and also accept and cope with problems that can't be changed. So that's the basic problem-solving therapy model, and our pictures do get better every year from whatever interventions are that happens. It just seems to get just nicer and nicer. And I think one of the key lessons here, my colleague UJ Jacobs is here, and he was a registered counsellor who's responsible for the training and the counselling of this particular group, is again how important it is for this kind of supervision. We have learned so many lessons that we've gone forward. It's a little bit trickier in Project Mind than it was for Teachable Moment, because the dedicated counsellors or the designated were almost sometimes the only one at those sites. It wasn't as grouped like it was for Teachable Moment. So that's kind of supervision was even harder to hold and contain. But he did it very well. And I think what's really important, as he's mentioned in this paper for his MPhil, is there's a very fine line between task sharing and task dumping. And that really depends on how strong your supervision model is. So this just give you an idea about our follow-up rates. So we had 24 clusters divided into the 3. And as you can see here, about many people got this intervention. So over 72% basically got intervention, received three sessions. We had really high follow-up rates at 6 months and 12 months. And even at the 12-month, we had 86%, 87%, and 91% follow-up rates. So we had a very good process at this stage to make sure we got the patients that we needed. But what did we find? I'm not going to go into too much detail. This paper should be out shortly. But as you can see, so compared to treatment as usual, we found more change on depression at 6 months and 12 months in the dedicated and designated arms. So what does that say us? Our intervention is working really well for depression. But looking at the alcohol-specific findings, the dedicated arm was much better relative to treatment as usual. Yeah, and so this will be coming out soon, but I think what it has been telling us is that task sharing is acceptable, it's feasible, and it's effective in these very large numbers. It just has to be done very, very well. Yeah, so the findings of this study and other ones, we've done it in many, many different populations with pregnant women, with other HIV populations, and it's now being tested in other countries as well, such as Ethiopia. The Western Cape Department of Health and Rural have also confirmed that they would like to train all of their counselors in the Project Mind training. So we'll be starting that shortly. Moving on to solution 3. So in order for us to really narrow the treatment gap, we need to move towards a whole life approach that includes promotion and prevention programs. And I'm only going to be touching on adolescents here because that's where mostly my work has been, but it also is important across the entire lifespan. So why should we focus on adolescents? Well, we know that among young people aged 20 to 24 years, self-harm, depression, and anxiety are now respectively the 3rd, 4th, and 6th leading cause of disability-adjusted life years. This is massive. Adolescence is the peak age of onset. We know that 75% of symptoms start in adolescence. So catching it early is obviously going to have a much better prognosis for them later in life. We also know that since adolescents build the foundations for cognitive, emotional, and social resourcing for later in life, it is not surprising that poor mental health in adolescence predicts negative life trajectories. So again, I'm only going to give 2 studies as research spotlights, so we're going to be here for a very long time. And the first one is Project STARS. And Project STARS was done in collaboration with the WHO. It was done in a number of countries. We did it in collaboration with Jamaica, Nepal, Pakistan, West Bank and Gaza Strip, and of course us. And what they were really trying to do was to use human-centered design, so working with the adolescents themselves, to build an intervention that was going to be acceptable and feasible for them and their uses. So it wasn't researchers coming in and saying, this is what we're going to see if you like it. It was really the other way around. And it was quite an iterative approach, to say the least. But saying that, the end result was really quite interesting. So this is Chummy the chatbot. It ended up with 10 sessions of evidence-based specific treatments. As you can see here, it was delivered over Facebook. So it was done in their Facebook chats with not Facebook Lite, which is very important, definitely the whole Facebook. And you would have a chat with Chummy the chatbot. And I'm not going to tell you I'm not going to tell you about how it went. I think given the human-centered design, it's much easier to hear it from someone who really used it.
My name is Anthony Mafume. I am 18 years old. I am currently still studying. Chomi is like a very close friend. It really helps me emotionally. Chomi really had a very good impact on my life because it made me who I am today. With all the things that I have learned from Chomi, right now I can be able to accomplish each and everything that I want.
So that's just an idea of how Chomi is used and who is using it. Still very much early in our research development. We did a final pilot study at the very end with just 20 adolescents. This is the data that we found. So about 60%, you could argue, could be engaged. They had to have 6 sessions or more, and 40% disengaged. But I also want to say we did this, we had already halfway done this before COVID lockdown, so then we tried to implement it also during COVID. So we learned a lot about that, and it was done over digitally anyway, so it still was possible. But it may have had some implications for our engagement. And as you can see here, we are seeing it. This is a quasi-experimental design. It's not very rigorous methodologically, but it is showing that depression scores and anxiety are going in the right direction, which is what we wanted. And we're working forward to then apply for a larger grant to really evaluate the effectiveness of Chomi in our context. So the second research spotlight is Project Aspire. And this is really about expanding mental health counseling from primary care to reach at-risk youth. What did we want to do? Well, we wanted to look at identifying barriers to initiation, engagement, and retention for this population. And we wanted to focus again on depression and alcohol use. We're trying to keep them more transdiagnostic. You end up having all these silo projects, which can be quite problematic. And we wanted to look at how we could be adapting the intervention that we had for adults to this population to see even if it could be adapted, and if so, how would we do it? And then we wanted to conduct a feasibility trial as we move forward. So after a lot of formative work and working with the adolescents, we did a number of things. We added a stronger behavioral activation component for our adolescent group. It was very much needed, given some of the issues that they were struggling with. And then we added intervention more on emotional regulation. There are a lot of big feelings and anger that these adolescents were struggling with, and our initial intervention did not have that component. So generally, over the time, this was again done halfway during COVID. We stopped the face-to-face, and then we did the rest online. So we had about 107 participants that were then randomized to the two groups, 57 in the one and 60 in our longer intervention. We had pretty good follow-up rates, as you can see here, but we only did a 6-week and a 3-month follow-up, given the purpose of this is a feasibility trial. We weren't necessarily looking at effectiveness, and we weren't powered to look at effectiveness. So as you can see here, these were our 7 feasibility outcomes. We had met all of them except for 2, and I do blame COVID for this. I'm sure it's not the best thing, but it's definitely possible. So we did want to have 5 participants per week, and we only made 3. And we did just check how many numbers we had before COVID and after, and we definitely see a difference in the numbers from pre and post-COVID. And we also wanted to have 70% retention in our intervention, and we only met 67%. That could have also been due to COVID, but I think we've made some suggestions of how we would make this intervention better going forward to address this. And again, so although we were not powered to detect any differences, we found a very strong difference for anxiety, but all the other outcomes were going the right way. So we feel very promising. We find this intervention is going to be very helpful, but do want to test it more rigorously before we try to roll it out. Right. And there's just 2 other studies that I wanted to mention, or projects, not necessarily any data yet, but definitely worth mentioning. So the ALIVE project is funded by the Wellcome Trust and is led by Crickland and Mark Jordans from King's. And the overall aim of this project is really to develop and pilot test an intervention that equips adolescents living in poverty with skills to strengthen their self-regulation in order to prevent the onset of depression and anxiety. There are 3 countries involved. It's Colombia, Nepal, and us here in South Africa. And we've partnered with Waves for Change, the NGO. And again, we're only in year 1, so we don't have any data to show you, but I'm hoping that in the next few years we'll have a lot to say about the lessons learned and how we can move this forward. And then the other initiative that is really exciting is the Sue Struman initiative, and it's funded by the Sue Struman family in 2020. And the purpose of this initiative is to address the mental health implications of childhood trauma and adolescent adversity. What this initiative does is it funds PhD students every 3 years, fully funded, and we have 2 at the moment. We have Mary McKeesey, who's working on the younger adolescent population from 10 to 14, and she's looking at adapting the WHO EASE intervention. And we have Chesney Ward-Smith, who's here as well, who's looking at the older age group, 15 to 18, and we're looking at emotional regulation intervention for that population in schools, and integrating a sports component to there as well. And I think what's nice about this initiative is this doesn't only add the capacity building for our students, but it's really going to push this area forward over the next many years to come. Right. And so given the moves towards us working with adolescents, there was a clear need for the establishment of this adolescent action team. We're excited to say that we had 25 applications. I think we had 26 applications, but 25 are coming into our adolescent advisory action team. And it's going to be led by our new colleague here, Azola Sambanda. So he is our adolescent advisory liaison, who is starting with us in August. And we're really hoping that this long-term engagement and commitment will really allow us to take this work forward in a meaningful way. Right, and solution number 4, investment in mental health research capacity in Africa. So although we've seen a little bit of an increase in this over the years, it's still not the same as it would be for HIV and other areas. There really is a need for mental health research capacity building in Africa, led by African public mental health researchers and practitioners to drive local research priorities and retain precious human resources on the continent. I think this is really important. So our postgraduate training team is here. It is jointly run by us in psychiatry and the psychology department at Stellenbosch University. It's run, so Claire van der Westhuizen is here, and she's our lead and is the deputy director of the center. She leads this along with Sangelo Mobo, and we also have Ashraf Kaji and Rizwana Romani, who's also on the Stellenbosch side, and they really take this kind of work forward, and we're only getting more and more students as we move forward. Our MPhil and PhD program has been going since 2012, and is currently the only mental health program in Africa on the continent. We've had 37 master's students graduate and 6 PhD students so far, and it often includes clinicians, lecturers, health service managers, policymakers, and community organizations. So I think what's really nice is we have a very strong NGO component in our MPhil and our PhD programs. These are just our graduates. We always want an opportunity to celebrate our graduates, and because COVID, we're keeping the 2021s, and hey, that's from 2020, and of course 2021. We've seen so many, definitely an increase in our students over the years. And currently we have 18 students registered in MPhil in our program, and 9 PhD students. We are seeing more and more people enrolling in our center. So CPMH has recently received further funding to expand our research capacity building objectives. The African Mental Health Research Initiative, or MARI-1, was funded by Wellcome Trust and was led by Dixon Chibanda from Zimbabwe. MARI-2 has recently been funded as well, so we're going to be further expanding on this in the next 4 years and really solidifying our relationships. And then ARISE is funded by Fogarty, and it's really driven by Claire van der Weisthuizen. And I think what's really nice about ARISE is it's allowing us to develop a PG dip that can really close and put our whole postgraduate portfolio together, which is really exciting. So the idea is that many of the people who are applying for our MPhil program wouldn't necessarily have the right qualifications, but those who sometimes did get in were taking a long time to finish. So really the idea, and as things got more competitive as well, many people weren't getting in simply because of the nature of the program. So this will allow a little bit more equity and hopefully really build on public mental health on the continent. All right, solution 5 is to focus on innovative mental health research that addresses global challenges. So I have already kind of spoken about this, but we want to expand the focus on scaling up treatments to also focus on prevention. I think this is really important. A lot of the work we have always been doing is to focus on adults and treatment, and it's time to kind of expand on this. We want to move from randomized control trials to implementation science. We know what works, we just need some more information of how it works. We want to try to be a bit more innovative and try to use digital platforms a bit more to see if we can increase access and address many of those barriers to treatment. And we want to continue to expand our focus onto adults, including youth and the growing aging population. I think that's quite important. So I think what we're looking at here is we really all have our part to play in this treatment gap. So looking at solution 6 is really to continue to foster a global mental health community. So given the large treatment gap, we're all going to have to play some kind of role. And many of us have very different hats. Sometimes you might be a healthcare provider, you might be a doctor, you might be a nurse, you might be an OT or a social worker, you're a parent, a friend, a teacher. We're all working in this together to build this kind of community of practice to move global mental health forward. And I think that is really the only way we're going to be able to close, or at least narrow, this mental health treatment gap. So just to end, I have so many people to be thankful for. I probably could spend a whole 45 minutes, but I'm going to keep it very short. I've had so many mentors, whether it's been academic mentors or peer mentors, that have really pushed my work forward, and I feel very grateful for all of you. Obviously, Faculty of Health Sciences and the Department of Psychiatry and Mental Health more generally, and all of CPMH. I don't know if anyone's who ever worked for CPMH. It is such a wonderful place to be. We all love going to work every day, and I can't imagine working for anybody else. And of course, my family hopefully is online from Vancouver Island, but also my partner Ian, who we always make a joke when it comes to grants. That we always have an interesting relationship with grants when you're in academia, that it always keeps coming back. As a soft-funded researcher, you're constantly writing these grants, even when you say it's over. So I really appreciate his patience. And of course to Callie, who managed 45 minutes of hearing her mom speak. And of course to all of you joining us here today and online, I really appreciate the time. Thank you.
Oh, congratulations, Kat, for a wonderful talk. Really wonderful to see all the work that you've been doing over the years. Professor Green-Thompson, Professor Stein, honored guests, ladies and gentlemen, it's my pleasure and privilege to give the vote of thanks for Kat's inaugural lecture today. So it's really a great pleasure to be here and to see so many friendly, familiar faces in the audience, and I hope online. So my job is really to tell you some stories and give you some perspectives from colleagues, students, friends of Kat over the many years of her wonderful work and her amazing career. So just by way of introduction, I was involved in helping to establish the Alan Fisher Centre for Public Mental Health in 2010, and I served as its first director until 2017, when I handed over to Kat. And it was always very clear in my mind that she was the right person for the job and that she would continue to take the centre from strength to strength, which indeed she has done. We've seen 37 master's students graduate from 11 African countries, and under her leadership, we've seen 8 PhD students graduated and now another 9 PhD students enrolled. Really just an amazing program of work which is building capacity for public mental health across the African continent. So I approached a number of different colleagues, friends, students to ask for their perspectives on Kat, to tell us some stories of what they knew about Kat. And I did some very detailed, rigorous, grounded theory, thematic content analysis to try and pick up some of the main themes that emerge from all these narratives. And so I want to run through some of these themes with you. The first is that people consistently spoke about Kat as an amazing team builder, as someone who cares for and supports the people that she works with. And her support for the CPMH staff during the COVID pandemic was really absolutely exemplary. She quickly sprang into action to set up a Friday morning online check-in meetings every Friday morning, and this still continues today. We all check in just for an informal conversation to see how people are getting on, both with their personal lives, with their work. She actively supported staff who were struggling. She also gave a lot of responsibility to staff to really do the jobs in the way that worked for them. And her concern actually extended to the animal kingdom. Her cat Chamberlain would frequently make appearances at our Friday morning check-ins. So she really is an amazing team builder and supporter. The second theme that emerged from this careful, grounded theory analysis was Kat's generosity. As Simone Honickman puts it, she's extraordinarily generous with her skills, going above and beyond to support the research of others through her kind and invaluable insights, even when there are huge competing demands on her time. She is invested in the advancement of other researchers and provides tangible support for this. Thirdly is the quality of Kat's work, and a number of people spoke about this. Ashraf Kaji says, Kat never compromises on scholarly excellence and her commitment to public mental health. I've seen the care and dedication that Kat shows the MPhil students. They are lucky to have her as a lecturer, and we are lucky to have her as a colleague. And so this is borne out by Kat's MPhil students. I had an email from Jafet Miaba, who's a former MPhil student, now lecturer in mental health at Kamuzu University of Health Sciences in Malawi. And this is what he says. Kat is just one of the great research supervisors and a motivator in mental health research. I am rated as one of the best supervisors to both my undergraduate and master's students in mental health research at our university because of the skills and knowledge gained from Kat's supervision in classes. So you really see the work that Kat does in building capacity for others, who in turn are building capacity for others across the continent. So they're really wonderful. Megan Milan, former MPhil student, now PhD student, says, in simple words, Kat is a mentor like no other. She means a lot to me, and I will forever be grateful for having her as a teacher, supervisor, and friend. Fourth, Kat has a very creative and innovative leadership style. Again, as Ashraf says, I've been working with Kat as co-director at the Centre for the past few years. Kat has always been highly collegial, creative, and innovative in her leadership style. She constantly comes up with new ideas and is excellent at bringing people together to make great things happen. As we know, the NIH system is hard to navigate, but in the ARISE application, Kat was undaunted. She and Claire and others managed the application with aplomb, and as a result, we now have funding for the PGDIP for the next 5 years. It's an amazing achievement. And then fifthly, and Dan has commented on this already, Kat has a unique and amazing sense of humor. So I don't know how many of you know, but my office is right next door to Kat's. And typically what happens at meeting times is people will file into Kat's office and the door will close. And then I'll start to hear these peals of infectious laughter bursting out of Kat's office. And it kind of carries on for the whole length of the meeting, and then it reaches a crescendo right at the end of the meeting when everyone sort of bursts out of the office and they all go their way happily. So that's a fairly consistent trend. Ashraf says, I know Kat is a friendly and fun person with a great sense of humor, always approachable, always engaging, and always concerned with the well-being of others. Others have noted, although public mental health is a serious topic and the dire state of public mental health is distressing, Kat always brings enthusiasm and optimism to the task at hand. The focus is on what we can do and how we can problem solve or find a system workaround rather than resignation and acceptance of the status quo. And then the sixth and final theme is really that Kat is somebody who walks the walk. She doesn't just talk the talk. Someone said, Kat embodies the spirit of public mental health. Apart from her research and advocacy role, she genuinely connects and maintains connections with providers, participants, and research teams in the places she works. During her PhD, she worked closely with traditional healers in the Eastern Cape, often driving them from place to place in her small car. More than a decade later, she has maintained relationships with them, dropping in to visit them on a recent road trip to Gauteng. And as other colleagues have said, Kat is also one of the most community-minded people I have met. In research terms, she is often the person who will go the extra mile for others who are struggling with personal issues. She's offered the use of her home, her vehicle, and has provided other material supports to research team members struggling with one or other difficulty in their lives. And as others have said, she's a highly principled and consistent person in acting according to the principles and values that she upholds. Part of this is knowing why the work is important and wanting to see evidence-based practice implemented. Her behind-the-scenes work with SADAG, the South African Depression and Anxiety Group, and other community organizations are examples of her commitment to improving public mental health practice. This kind of work may never make headlines, but it's important for driving practice change. I thought I'd finish by just sharing with you some of Kat's unique sayings. She has a certain turn of phrase, which I think some of you may be aware of. She uses the term binge it quite a lot. That's quite ironic for somebody who does research in substance use, treatment and prevention. But for Kat, binging it means focusing on a task, getting a group of people together and getting it done. So that I hear quite a lot. Wing it is another one she uses quite a lot. Jacob says, one of my funny recollections is that sometimes organizations would request at short notice for us to present and or provide mental health training. While we were stressing during preparation and feeling ill-prepared, Kat would listen to what we have arranged and prepared and just say, this is great, just wing it. The third phrase, or Katism as I call it, is divide and conquer. So Kat uses this quite a lot. It simply means when the load is heavy, share it. And then her final one, which I really like a lot, is it is what it is. And as someone said, it is what it is something that Kat will use often when you can't solve a problem in projects, and it gives us more to write about. So Kat, really on behalf of UCT, the Faculty of Health Sciences, the Department of Psychiatry and Mental Health, the Center for Public Mental Health, and all your many partners and students, we want to say a huge thank you for all that you've done. Thank you very much.
Thanks very much. I must apologize. I took a list of names at the beginning and then I forgot to say any greetings to anybody when I started. I just wanted to show you the slide, and I want to thank Timbagazi Sonobe and their team for the slide that really is trying to capture the spirit of our 110th celebration. We want to bring in the voice of the original peoples of this area with the Kaikangans, and particularly Indao Yenkwenkwezi, which is the Xhosa translation of Place of the Stars, which observatory is. But I do want to say special thanks to Ian and Kelly and Kat for being here, because I think we don't always see the people behind the people that we work with and create difference with. So I'm really grateful that they're here, and thank you very much for being a part of the celebration. Colleagues, I'm going to ask you to stand as the academic procession leaves, and I'm going to ask Kat and Kelly to lead that out, please.